Hey everyone, welcome back to Pain Consultants USA podcast. Tonight, this is episode 8, and Dr. Bonner and I are going to be talking about a topic that was actually requested by an individual who's suffering with this condition. So we're happy to kind of dive into the weeds on this tonight and explore kind of all aspects of it. So we're talking about failed back surgery syndrome. You might also hear it called post-laminectomy pain syndrome. Uh, what it is people who have had surgery and they continue to have back pain and or radicular leg pain. Some people call that sciatic pain. So we're really going to kind of dive into why it might happen, who's at risk, how we approach patients when we see them with this condition, as well as what are some potential treatment options. I think this topic is pretty broad. There's a lot of useful information, hopefully, that we can get across and available to you guys and girls tonight. So I'm sure we'll probably expand on some of these topics in future podcasts as well. That being said, how are you today, Dr. Bonner?
Doing well, thank you. How are you doing?
Uh, good. So, why don't we jump right into it? And why don't, if you could, can you let us know how you approach patients who might present to you who have had previous back surgery and continue to have pain?
Yeah, absolutely. One thing I guess we should say is that this is very common, and we could get more into the specific numbers, but for different types of back surgery, it may range anywhere from 20% to 40% of surgeries that end up uh, with the patient having some type of back and or leg pain in the future. So this is very common for patients who have surgery, and we need to kind of thoroughly evaluate why it's happening. And so I really like to dive into the details with the patient. So that starts with, tell me about your pain before you ever had surgery. So where was it? What made it worse? What made it better? Kind of all the things that we always talk about. And then all the treatments that you had for it prior to surgery. Did you have every appropriate treatment? Did you give it every chance you could to not have surgery? Or if surgery was urgent, why was it urgent? Maybe you had some loss of control of your bowel or bladder, or you had weakness in your leg and you had to have like emergent surgery or urgent surgery. So I want to know all those details so I can get a picture of what exactly was happening and why surgery was done. And then you really want to know kind of what surgery was done. So where was the surgery targeted? Why was that area targeted? Maybe you can fit the patient's description of the problem they had with why they had the specific surgery. And hopefully we have some records related to that when we're seeing the patient. We have some details from the surgeon about what exactly the procedure was done. So then after that, you really want to know, so what happened right after the surgery? Were you better right after the surgery? Did you never get better? Okay, so if you never felt better and you had the same pain before the surgery and after the surgery, it's possible that the surgery didn't address what was causing the pain. Okay, um, if you did get better and then develop pain later, well, then we need to know about, okay, when did that pain start to develop? How did it develop? Was it sudden? Was it gradual? And is it in a new place, or is it the same exact pain as before? Um, and so if it's new pain, then there's probably a new source of pain. And we know from treating these patients that getting a surgery may fix one problem, but you may develop a new problem related to the surgery. Most commonly, I think we've referred to in another podcast is kind of adjacent level disease, where above or below a fusion surgery, you may get a new problem. And that's something we can definitely talk more about. Um, and so then we need to know the details of all the new pain, what makes it worse, what makes it better, what treatments have been done. And, then we can kind of sort out from there. Is it something new that needs new evaluation? is it the same thing and the surgery didn't do anything before? And so that's kind of the details that I'm trying to figure out when I see one of these patients, to try and sort out kind of if the surgery did anything at all, and if it's a totally new problem, or if the surgery didn't address the issue and the same issue has been going on the whole time. I don't know what you think about that.
Yeah, no, I think that's a great way to approach these patients when they come in. I, I tell a lot of patients this is some of the most complicated stuff in medicine, is, in my opinion, is being able to um, uh, first figure out and then treat successfully chronic pain post lumbar spine surgery. Just to expand on some of those numbers that you had mentioned with regards to potential failure rates. Uh, and this kind of ties into discussing the types or broad categories of surgery that can occur. For the purposes of today's talk, we'll primarily be focusing on the lumbar spine. But right, so three surgeries or three types of surgeries. One would be what's called a discectomy. So if somebody has a herniated disc touching a nerve with pain going down the leg in that same distribution, oftentimes younger patients, a surgeon might go in and just remove a piece of disc and relieve the pressure. So when you look at neurosurgical literature as well as pain medicine literature just on discectomies, which are the simplest type of low back surgery, I guess you could probably call that. We're looking at failure rates between 15 to 25%, right? So just for comparison, you think of people who undergo like total knee replacements or hip replacements, usually a pretty successful orthopedic type surgery. The numbers that I see quoted are, failures in that regard are 10% or so. Then the second type of surgery that we'll talk about is more of a decompressive type surgery. These are laminectomies and potentially foraminotomies, which we talked about a little bit in our last podcast with people who have spinal stenosis. So in these situations, the literature says, a failure rate can be as high as 30 to 35%. And then you move into the most extreme of back surgeries, being that of a fusion, where they'll actually put hardware in to prevent any movement at that one segment. And those numbers can be as high as 30 to 40%, if not higher, depending on if it's your first fusion or second. So uh, this is not to talk bad about surgeons, because I know sometimes we talk about probably minimizing their role, but obviously spine surgery is needed. It's not going anywhere. And when done appropriately, it can be life-changing. But oftentimes, these are very difficult conditions to treat just surgically. And you go to the best surgeon in the world, but these are the numbers, right? So the failure rates are going to be much higher than any typical orthopedic procedure, and our patients should be aware of that going into it.
And I think that speaks to the complexity of dealing with chronic back pain. It's a very difficult condition to treat in general. And even if the surgery may address the actual area where the pain is coming from, the patient may still have chronic pain related to many other factors that kind of lead your brain and nervous system into adopting this chronic pain state. And so, even if the area is addressed, you may still have a problem that's unrelated to what was happening in the spine prior to the surgery. And so that's also important, I think, for patients to understand, because the surgeon may have done a fantastic job of clearing up the issue in the spine, but your nervous system and your brain has learned that pain signal and won't let that pain signal go anymore. And so you're still experiencing the same pain, even though the pain generator really isn't there anymore.
Yeah, and that's a very important topic to talk about. So I would group that into chronic neuropathic pain, right? So um, uh, especially when you have back pain that travels down your leg. I guess we should back up for a second and kind of review that most lumbar spine surgeries, the goal of those surgeries or who they should be performed in is in individuals who have back pain and pain going down the leg. A good surgeon will tell you lumbar spine surgery is much more successful. So having surgery on your back is much more successful at treating leg pain than it is back pain. So with that in mind, oftentimes the leg pain is because of a nerve issue. And the nerves, they start at the brain and they travel down your spinal cord, and then they'll form little nerves and they'll exit the spine, go down your leg. We now know that there's actually changes that occur throughout all these various levels of what we call your central nervous system, or the brain and the spinal cord, as well as your peripheral nervous system, which is the actual nerves in your legs. I tell my patients it's almost like a light in your house, right? When the switch is on, all the signals are running through the wires. When the switch is off, everything kind of stops. And when your switch is on, you're experiencing pain. And when you're resting or not really doing too much and not performing activities that would normally cause pain, that switch should be off. And people with chronic nerve pain, their switch is still on. All these little kind of chemicals and little reactions and electrical impulses are being fired off and telling your body that there's pain, and that's how you interpret it in your brain. Um, those types of things oftentimes can't be corrected with surgery. So, that is one common reason that I see people continue to have chronic nerve pain after surgery is this whole cascade. It hasn't really been thought of too much. We always think about, oh, we see an issue on the MRI or CAT scan. Surgeon says, well, I could fix that. I could go in and remove that. Well, it might make the picture look better, but the pain's still there because surgery won't address necessarily the altered signals that are being transmitted.
Right. Right. We see a lot. I think we see a lot of those patients because they end up coming to us after kind of the surgeon does the surgery. They don't feel better. They get repeat imaging to make sure the surgery is intact. They're told to wait a bit of time because it takes time to get better. They wait. They still don't feel better. They get some final imaging to make sure that, everything's okay. And then, they say, well, the surgery's done and we did what we could, but you now go see the pain management doctor. And then we're kind of left with these patients trying to help them through the chronic issue. And that goes back to the evaluation. So did the surgery, from my standpoint, really address what's causing the pain? So we need to always be aware that there might have been another issue that wasn't addressed, and that may have been whatever issue was addressed in the surgery may have been kind of a red herring there. It may have been distracting from what was really causing the pain. So we always want to identify that pain generator so that we can make sure the treatment is appropriate.
Yeah, and I would encourage patients, obviously those who haven't had back surgery but are contemplating it, or those who have had back surgery and are contemplating a second one, to, you really should be evaluated, in my opinion, by a skilled physiatrist, which is a physician who specializes in physical medicine and rehabilitation, who has an emphasis on spine care. And then before any spine surgery, I tell my patients you should get two opinions. If the opinions are completely different, that's a red flag. Maybe a third opinion, but that would be alarming to me. And then we sometimes have to say, you know what, well, maybe we don't have the best idea as far as what the true pain generator is. If the opinions are the same, then, in addition to our evaluation and kind of the appropriate treatment, we might feel a little more comfortable with considering something like that. I know we've talked about this in previous podcasts, but it can't be kind of stated enough. When you make a decision for a spine surgery, obviously, I mean, that's permanent. Can't go back from there. And when you look at the data, whether it's in the neurosurgical literature, right? So these are the surgeons, they're putting out this data as well, or physiatry or interventional pain. When you compare a lot of these groups, whether they have surgery or non-surgery treatment options, at 2 years, a lot of patients are doing pretty similar. Now, I know it might sound kind of crazy. Well, I can't wait 2 years to feel better. But when you're in your 30s, 40s, or even 50s, and you have decades of life still to live, my argument would be maybe it is worth waiting a little longer, as long as there's no, red flag sign or symptom that we've talked about before that necessitates surgery. If it's primarily because of pain, maybe we wait a little longer. Maybe we're doing a disservice to our patients by, kind of moving them along the wheel of kind of the medical system right now with, okay, well, if this didn't work, go here. Okay, that didn't work. Well, your only other option is surgery. Maybe we should pump the brakes and say, you know what? We just got to give this time, kind of reset expectations. What are your thoughts?
Yeah, I mean, I think I've learned to kind of incorporate that early when I sense patients kind of considering surgery for things that I don't think require surgical treatment. Just let patients know that this will get better, but it will take time generally. And there's other things we can do along the way to hopefully make it feel better so that you won't have to suffer for so long. So, I think, like you said, as non-surgical specialists, we really need to focus on trying to find patients the best treatments. And like you said, there's no turning back if they go to surgery.
Who? I'm sorry to interrupt.
No.
Who? I guess when you evaluate patients, who are there certain things that you'll see or learn about patients through conversation and evaluation that might say, you know what, for this reason, I would recommend against surgery? Like, are there certain kind of factors like that will kind of alter your decision making as well about who might be a surgical and non-surgical candidate?
Um, well, as long as they don't have any red flags, which we always mention,
Mm-hmm.
kind of weakness or numbness in the legs, bowel or bladder incontinence, anesthesia or saddle anesthesia, can't feel your genitals or rectal region. Those are kind of the main ones that we always mention. As long as you don't have those, I think some people that we talk about that might not have a great result with surgery might be people who are on opioids chronically, people who have had other back surgeries previously, smokers. I think I knew a spine surgeon during fellowship who wouldn't even do an elective spine surgery on a patient if they were a smoker. They had to quit smoking, or he refused to do the surgery because they've just been shown to have poor results. Whether or not that's related to the healing or the interference of healing by the smoking, I don't really know. But those are some of the people that come to mind that maybe we try to steer away from surgery. One thing I found also, I think, is that some patients tend to choose surgery themselves, because if a patient wants surgery, they're going to be able to go out and find surgery in most cases with back pain. And so there's certain surgeons that are probably more likely than others to do surgery, and there's certain patients who just don't have the patience. Maybe, I don't know if it's ever been looked at, but maybe people with more type A personality that they really just like can't slow down and can't rest enough to let the pain get better. And you see some of these people and you tell them, look, this will get better with time and some of these things that we do, but they just don't have the patience. They might give you one chance at a couple of sessions of physical therapy, one medication, maybe one injection, and then they say, okay, I need surgery, I need surgery, I need surgery. I can recall patients like this. And then you get other patients who come in and they say, I'm definitely not getting surgery. So they're just never getting surgery unless like you force them to emergently because of some really bad issue, which in my experience has really like never happened. So, there's some people who come in right off the bat and say, I'm not getting surgery. And then also we are non-surgical specialists. So I think part of the patients that we see, we get kind of selected by patients who maybe aren't looking for surgery. So a patient, I know at a hospital system I was at before, when patients used to call with back pain, they would call the kind of the hotline for the hospital, and they say, okay, I want to see a doctor, I have back pain. And so one of the questions they would ask is, do you want to see a surgical specialist or a non-surgical specialist? So right away, the patients were kind of choosing themselves which doctor they would see. And you can imagine that probably more of the patients who wanted to see the surgical specialist were more likely to consider surgery. And a lot of the patients who choose a non-surgical specialist are probably doing that because they really, really don't want surgery or won't have surgery at all. And so there's always kind of those odd factors kind of playing a part in this, that maybe certain patients will force their way into surgery sooner, and some patients will just never have surgery because that's what they think. I don't know what your experience with that is.
Yeah, I mean, I definitely think there's a population that kind of self-selects. They make up their mind early. The practice I'm currently in, I think we see a lot of patients from the surgeons. A lot of the surgeons want to maximize non-operative care first, but in those patients too, sometimes, yeah, they have it in their mind, surgery fixes everything. So it's kind of hard to convince them otherwise a lot of the times. You mentioned the smokers. I think should be universal at this point, that any elective spine surgery shouldn't occur unless you quit smoking. Another big one is diabetes. So in my fellowship, I had a neurosurgeon who would not operate if blood sugars were not well controlled with the A1C, which is a 3-month average of blood sugar. So that was another big one with regards to healing.
And you think that should really be almost any surgery. You see routinely throughout your experiences in residency and everything, that people that are diabetic with uncontrolled blood sugars, they don't heal well, and that's a major issue. You don't want to have surgery if you especially don't want to have elective surgery if you're not planning on healing well after the surgery. That's just increasing your risk of infection and other complications. So you say it should be routine, and spine surgery should be routine like everywhere, but and it probably is for a lot of surgeons out there. So that's just something that's, if you're diabetic, get your sugars under control.
Yeah, no, I think especially as we're moving to more of an outcome-based measure kind of healthcare model, I think everybody's a little more conscious of these factors. The other big one is opioids, which could be somewhat controversial, but the data again shows people who are on a higher dose of opioids going into any type of surgery oftentimes do poorer, right? They have worse outcomes. The argument could be made, the chicken or the egg type issue, but I know with my patients, if they are on an opioid before surgery, oftentimes we will try to wean them off, leading up to surgery. So there is something to that. And the last thing that I think we always have to talk about when we're discussing chronic pain is that of depression, right? So Doesn't matter how strong you are. Chronic pain will wear on you mentally as well as physically. You'll get fatigued, and once that kind of mindset occurs, again, no fault of the patient, but then you start making decisions that you might not have made 6 months ago or a year ago. And oftentimes, sometimes it's the depression that's leading or the primary driver of the pain, right? You have pain, but your pain is escalated because you're so down in the dumps because of the pain. So it's a vicious cycle. But that is something that should be addressed. And, with certain interventional procedures, such as like spinal cord stimulation, which we'll briefly talk about in a little bit, it's mandatory that you see a psychologist or psychiatrist beforehand to kind of rule out any severe underlying depression as the cause of your pain. We should probably consider that for a lot of other type of surgeries as well, especially spine surgery.
Yeah, and you see that definitely, bariatric surgery, there's a big workup that goes into that involving, there's definitely a psychologic evaluation prior to that, so you do see it in some places, and maybe it could be spread more for other procedures and other types of treatments too, just like you're talking about.
Yeah. So why don't we next kind of talk about pain after surgery? So let's first maybe start with non-fusions. So more of like a decompressive or discectomy type procedure. Mm-hmm. And so there's no hardware in the back. Patients come in with persistent back pain, or we'll say recurrent back pain after the surgery. So we'll just focus on back pain first. So what kind of things are you looking for? What are some common causes of back pain after a decompressive type surgery?
Well, I think when we talk about, the one type, the discectomy, we always want to think about, okay, they could have had a new disc problem. Okay. We've talked about kind of disc herniations and how you can have just kind of low back pain. You can also have pain down the leg, but you can just have low back pain. And so sometimes you can get a new disc herniation after a discectomy surgery, and that can give you back pain, or that can give you back pain shooting down the leg. What are the other main sources of pain that we talk about that may or may not have been addressed in a surgery? The facet joints, which there's lots of them. There's two on each side at each level of the lumbar spine, and so those can be painful. And the other thing we talk about sometimes is the sacroiliac joint, which could also be painful and can be commonly kind of missed as a source of pain prior to surgery. And so maybe the surgery didn't address that as a cause of pain. So I'm always, those are probably the three main sources I'm always thinking about as sources of more axial low back pain. What else? What do you think?
Yeah, no, I would agree with that. I mean, so if you've had a discectomy, you would have had back or possibly back pain and leg pain.
Right, usually leg pain for sure too.
Yeah. So if you have persistent back pain after the surgery that never went away, my first thought is it's disc, right? It's kind of an expected outcome, right? Discectomies aren't going to treat back pain.
Yeah.
Right.
Great point. So if you had leg pain before the surgery, you had the surgery, mm-hmm. the leg pain's better, but you still have back pain. That's not really unexpected.
Yes, right. That would be an expected outcome, right. And that that's on the physicians to explain to patients before the surgery. Right. If you had the discectomy, you didn't have much back pain beforehand or after, you were doing quite well, and whether it was 6 months, a year later, you might have developed worsening pain. I would then talk about, is it a new disc? Is it a recurrent disc, right? You can get recurrent disc herniations at the level of your surgery pretty commonly.
Uh-huh.
Right. Let me see on this little model if you can see here. Right. So the red little bulge there again is that disc that's coming out and touching that nerve that exits the spine here. So as it sounds, discectomy, depending on where it is, they'll come in, remove this little piece of disc, but you can't patch up the disc. You don't prevent it from, you don't push the contents back inside. So theoretically, there still is a weak spot in the disc for more of that kind of jelly that we've talked about inside the disc to kind of leak out over time. Um, but again, the farther we get out from spine surgery for a discectomy, but you still have back pain, that's where I oftentimes will think about from the joints, either the facet joints at that segment or the SI joint. On this little model, if you can see, right? So I'll give you, so the disc is obviously worn out, right? It's almost bone on bone. The two bones here are almost touching each other. When this happens, it places a lot of stress on the backside of this segment, right? This is one segment, one vertebrae meet with the disc, meet with the joint on each side. So when this is worn out, more stress taken by the backside of the spine and will cause earlier arthritis and issues like that. So
Yeah, I think
I
that's
would agree with you.
classically the Kirkcaldy-Willis degenerative cascade of the spine, right? The disc
How about
degenerates
that?
first, and then because the disc degenerates, the facet joints then degenerate because they get more stress placed on them. So that's kind of it's a classic spine model that you can look up as a patient and try to understand kind of what's happening in the spine. And we talk about this over and over again. The discs degenerate when you're younger, and then later on you get facet joint pain. Well, why is that? Well, we stress the disc when we're younger, we degenerate them. That puts more stress on the facet joints because of exactly what Dr. Connor was just talking about, and then you get pain from those later on. So you're just kind of facilitating that sometimes with taking part of the disc out.
Yeah. And I guess when in patients who have had like a laminectomy, so more of the decompressive type surgery, right? So these are the patients who usually more stenotic, might be older. Again, it was covered in our last podcast, but just for completeness sake, so with the discectomy, they might go in and kind of remove this back piece of bone here. So the lamina, they kind of take it off, opens up the center of the spine. They might even kind of do a little rotor-rooter job where the nerves exit the spine. So they, again, just remove bone primarily. In those situations, uh, I might personally think less disc related and more kind of adjacent segment, joint related, just because once they remove bone, a lot of other kind of stress, abnormal stress is placed on some of those joints adjacent to it.
Right.
Would you agree with that?
Yeah, you might just get a little more movement than you used to have, a little less stability, and that may irritate some of those joints. I think that's when we see some of those joints really show arthritic findings on imaging, and that of course doesn't correlate with pain, but it makes sense that maybe that might cause a bit more pain in patients if there's a little more mobility there and the joints are a bit more irritated and less stable than they used to be.
And that brings up a whole other point, it's just dynamic instability
Yeah.
as the potential cause,
Yeah.
right?
Yeah.
Um, so yeah, there's a couple different features there.
Yeah.
Um,
Yeah. I think that's a whole
and
podcast probably in and of itself.
yeah, I think hopefully we can kind of build on a lot of these topics and kind of in future podcasts. So what about with decompressive surgery? So still no fusion, but now you have leg pain. So, right. So we'll kind of start from the beginning again. You have a discectomy, uh, and they remove the disc. Say the pain never goes away, or say it goes away for a while, then it comes back. What are you thinking?
So if it comes back really quickly, I would think more of a recurrent disc or a new acute disc. And if it comes back pretty slowly, then I think more about like scar tissue or like arachnoiditis, kind of the scarring or the scar tissue around the nerve kind of slowly locks the nerve down, and then the nerve has a tough time moving through the area where it's located, and then slowly that creates tension on the nerve, and then the nerve becomes kind of more and more painful as there's more and more tension. And those are kind of the two main things I like to think about, and you can sometimes tell the difference between those in an MRI when you get contrast. Um, there's a lot of question about whether or not we should use contrast these days. With an MRI, it's gadolinium, and maybe gadolinium deposits in your brain and other areas, and we don't really know the details of that and if it really causes any issues. So I tend not to order too many gadolinium studies. I think a lot of times a good radiologist can tell the difference between those things on an MRI, but that's kind of what I'm looking for when I see that patient.
Yeah, I mean, I don't have too much to add with that. Again, just always keep in the back of the mind, is it that chronic neuropathic pain cascade
Yeah.
that, it doesn't matter what the MRI looks like, but these are changes occurring in the spinal cord and nerve and even the brain that, we can't see and we can't fix by doing something to it. So something else just to keep in mind.
Right. Right.
But I would definitely rule out recurrent disc herniation or scar tissue formation. Now, scar tissue is a tough one, even for me, and I'd like to get your opinion, because once you heal, right, you get patients still have pain. You'll see some scar tissue formation. I guess it's a natural kind of healing process, right? So, I mean, sometimes we see scar tissue that wraps around a nerve or encases the nerve, so that makes it a little easier. But like, have you kind of come across that where, oh yeah, you have scar tissue, it's in the area obviously because you had surgery there, but I don't really think that's the cause.
I've definitely seen
It's
it
tough.
where I don't think it's the cause. I would say I've definitely seen that, but I would say more often than not, when I'm seeing it, it's related to what I'm looking at. I think that's
Hmm.
more my experience. I don't see too many younger patients these days, so I'm not seeing too many disectomies. So maybe I'm probably not seeing too many patients with that problem, but I think my experience has been that when I'm seeing it, it's typically been related to what I'm kind of expecting to find with the patient.
Yeah.
Do you think you see
Okay.
it a lot where?
I mean, I feel like we probably see it more in patients who have some of those risk factors that we talked about going into surgery, whether they were smokers, diabetics, poor wound healers for one reason or the other. Um, Something that we should always think about, and it's kind of hard to know, but surgical technique. Um, that's a real tough one, but does that have a factor in this as well?
Yeah.
So, um, but yeah, I would agree with you. Oftentimes, it's in the area of question, and it kind of fits with everything that's going on. We don't see a new disc herniation, but you have the scar tissue there.
Right.
So, um, okay, so we'll kind of save treatments till the end.
Yeah. You want
So
to?
let's move. Go
I was
ahead.
just gonna say, you want to talk about fusions now?
Yeah, yeah. So back pain after fusions. Go.
Yeah. Go. Okay. um, so I think I mentioned it before, but the thing we always think about is adjacent level disease. So above or below which segment is fused, just naturally gets more motion because you've locked one of the segments of the spine. And so if you're moving the same as you did before, that motion that you used to get from the segment that's now fused, you're not getting there anymore. So it usually goes to the segments above and below, which increases the rates of degeneration there. And then subsequently, you're more likely to get pain there. One other thing we always need to think about is the hardware from the surgery okay? So if there's a fusion, typically these days that's done with some type of metal placed into the spine, screws and bars. And so in the past, if you see some patients who had surgery 30, 40 years ago, they may have used a chunk of bone to fuse the spine. So they may have had a piece of their pelvis taken out and then put into their spine to kind of fuse that in place. And so you may see a different picture there. But more recently, we'll see a lot of kind of screws in the spine. And so we need to see, are those things okay? Are they in place where they're supposed to be? Or are they infected? They could be infected or they could be loosening. And so those are important things for us to look for. And then, of course, if the lowest segment in the spine is fused, the L5S1 segment, the next joint down from that, as opposed to being another segment of really the spine, is the sacroiliac joint. And I always look out for that as a source of pain for people who have the L5S1 segment fused there.
Yeah, I mean, similar to the others. I mean, always have disc issue above or below.
Yeah.
Most people are getting fused for one of two reasons. They have disc pain, right? So at the segment, the disc is causing the pain that hasn't responded to any other treatment options. So the thought process is if you fuse it, can't move, can't get pain. And then the other, especially the type that I see, would be such a large decompression type surgery. They remove so much bone that it would cause the patient to be unstable. So they almost have to put the hardware in
Right.
to just stabilize everything.
Right.
But yeah, very common, the joints above or below the fusion. I would just comment that some would make the argument, well, you have to fuse the next segment or the SI joint. Um, all I tell my patients is with each subsequent spine surgery, especially if you're talking about multiple fusions, the success rate just keeps going down, down, down. And the first fusion, you have a success rate of 60 to 70%. The second, you're looking at maybe 50%. Third, fourth, obviously much less. So just something to keep in mind as well.
And I would say, if you're thinking like that, we think about why does the stress happen kind of above or below the fusion, again, because there's more movement there. Well, what's a way to prevent that? And if we like dive into some good physical therapy or some good rehabilitation technique, we can figure out ways to increase movement elsewhere in the spine. So you have 5 lumbar segments, but you have 12 thoracic segments, and each one of those can rotate a little bit. So if there's a couple degrees of rotation in each segment for, say you want to say T1 down to L3, and maybe you're fused below that. Well, if you can add 1 degree to each of those segments, that's, what did I just say, like 15 segments. So that's 15 degrees of rotation that you can add to your spine, and you can spread it throughout the spine as opposed to kind of adding most of the rotation at the level just above the fusion there. So, you don't have to think about it like, oh, well, now there's more pressure there. Well, you can put the pressure elsewhere with appropriate kind of rehabilitative techniques, and one of them is to kind of move the motion to different segments that may be able to tolerate it better than the one that's just above the fusion there. And so that's always something that should be considered and thought about, especially prior to having another surgery.
Yeah, and one of the issues or the concerns I have with the way medicine is going is there's a big push now for not only spine surgeries, but other orthopedic surgeries. Well, quick discharge home, but then you don't really need much therapy. We can have therapy come to the house. It's all based on like home therapy, skilled nursing now, where the therapy at home it's not that it's not that good, right? They can only do so much at home, uh, and we could get into the reasons why there's a big push to home nursing or home therapy versus whether it's acute rehabs or skilled facilities and things like that. But just a concern I have with regards to patients receiving appropriate post-surgical rehab. So
Yeah, I mean, look, it's very important to have appropriate rehab after, a lot of surgeries that involve joints, tendons, muscles, kind of any musculoskeletal condition. And, if that's being limited, that's really a shame for the patient because, yeah, I think we would probably agree that it's just less likely to be a good long-term outcome if you have kind of less good post-operative care like that. So,
uh, and just to kind of round out, the back and leg pain after a fusion kind of goes hand in hand with what we said before: recurrent disc, scar tissue formation, fusions too, right? Obviously, like we talked about, adjacent segment, increased arthritis. The tricky part here becomes when you, again, I'm going to go back to this model here, when you increase arthritis in what we call those facet joints, right? It's just like a knuckle. Somebody gets older, the knuckle gets nice and big. These joints can get big, but then they'll push in on the nerves from where they exit the spine, causing like foraminal stenosis, we call it. Just describes where the narrowing is. That is another potential cause for recurrent pain down the road after a fusion. Okay, so patients had surgery, they come to your office. Um, what's your timeline with regards to kind of when you'll start treating outside of just a more of a physical medicine approach, right? We've tried to optimize the therapy, work on restoring motion and an appropriate motion above, below, work on core stabilizing, that type of stuff. So we're through that. What's your time frame that you tell patients, okay, well, if you're still having pain at this point, we should do something more?
One other thing I'll just add to the therapy thing is kind of what I like to refer to, I think, is neuromobility. So, patients, especially with developing leg pain, there's a lot of good exercises that you can do to kind of move, kind of like nerve flossing exercises to move the nerves, kind of if it's scar tissue, kind of kind of get rid of some of that scar tissue or move the nerve through the scarred area to prevent the adhesions and prevent the neural tension we were talking about before. This is another thing that's very important for, I think, especially some of these patients with leg pain. So, a lot of times I think in terms of timeline for when I might kind of start looking into other treatments after surgery, a lot of times I probably leave it up to what the surgeon is doing. Um, I don't I don't usually kind of step in to start doing different things until the surgeon has kind of told the patient, okay, this is expected time of outcome. If the surgeon is still telling the patient that, wait a couple more months and keep doing certain things, I'll kind of let them take hold of that. And then once they get to that point and the patient's, made their maximum improvement from the surgery or hasn't improved at all, I think that's when I tend to time it. I don't know. Do you feel differently about that? I just feel like I kind of let the surgeon decide how long they're going to kind of give the patient to improve after the surgery.
Yeah, I mean, one thing with surgeons in general, right? They don't follow up too long with
Yeah.
patients afterwards. So you might get a month follow, 2 week, a month follow up, and then a 3 month follow up. But um, you know,
I'd say it's
I'm
usually
sometimes
in that
I
like 3 to 6 month area, I feel like.
yeah, and I'll hear some patients and even some docs say, well, they said it could take up to a year to kind of feel better after the surgery. Um, that kind of goes back to, well, if you just waited another year, you might have felt better,
Right.
if 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 nothing's changed within 6 months of surgery, uh, I feel pretty confident to say, well, odds of anything changing as a result of the surgery in another 6 months are minimal at best.
Yeah.
So yeah, usually within like a 3 to 6 month period is when we might start talking about uh, interventions if appropriate. Um, but before we get into those, let's just talk about some medications for a second,
Yeah.
because obviously medications are used before surgery, throughout the recovery, and then afterwards. So um, non-opioid options, right? So we have anti-inflammatories, the Tylenols. Now we have to be careful. A lot of our patients might be older. Anti-inflammatories could be dangerous for them to use. They're not a great class of medications to use on a long-term basis for, kidney, stomach issues, heart issues. So we have to be careful with those. But so I would say the most commonly prescribed medications that aren't opioids would be the gabapentin, pregabalin,
Hmm.
sometimes duloxetine.
Yeah.
What are your thoughts on those? When do you consider using them? Do you feel like they're effective?
For the leg pain patients, especially, I think I find some good success with them. I don't find it's predictable at all. I will try it and I will titrate up and try to get an effect. And I think maybe a third of patients are ruled out within a week due to side effects, due to drowsiness or something, or some kind of cloudy thinking feeling that they get. Like I said before, I think I usually always start with gabapentin. Um, and then, I'll always give them a shot, especially with the leg pain patients. I treat a lot of geriatric patients at this point, so I really don't use a lot of non-steroidal anti-inflammatories. I just almost everyone's hypertensive, a lot of kidney problems, a lot of coronary artery disease. So I tend to stay away from those generally. I recommend a lot of Tylenol, and that depends on the patient. I think some of these chronic pain patients who had a lot of pain before surgery and keep up with a lot of pain, Tylenol is not going to be enough for them. Um, and the other thing I'll try is muscle relaxer categories, tizanidine, baclofen, maybe even more anti-spasmodic than maybe muscle relaxer. I guess you could put those in the same category or use them the same way, but some of those I do find some effect with in general, and I'll use those for back and or leg pain. And those are the main ones that main classes I think I go to before starting with like a an opioid trial if necessary. So, uh,
Yeah, yeah, I would agree with that. It is tough to predict who's going to do well with the gabapentins, pregabalins, duloxetines. Um, if they're having a lot of extremity pain, whether a large disc herniation or like foraminal stenosis, and describe a lot of that burning type pain, I'll use either gabapentin or pregabalin. In patients who have leg and back pain, and you just kind of get the sense that this is more of a chronic issue, especially if they had a lot of pain going into surgery. I'll consider more of duloxetine up front. Um, it also has some antidepressant type effects, which can also be beneficial in some patients. And then muscle relaxers. I always bounce back and forth. I never. It's like the flavor of the month.
yeah.
It's frustrating. It's frustrating with those. I tend to use those more if the pain stays in the back, I
Hmm.
would probably say. But I'm not overly impressed with them. And it's tough when patients come in, they say, well, part of the history is taking, well, okay, well, what medicines did you try, right? There's a bunch of different muscle relaxers. each one patients can have a different response
Yep.
to. So if you fail baclofen, doesn't mean you're going to fail tizanidine,
Right.
vice versa, or something. I like methylcarbinol as well. Um, so it does become a little bit of trial and error. But all of these medications, including the opioids that we'll get into in a second, they should be considered a trial, right? So if you go to your patient or your physician and they're going to give you something, well, tell them, just give me enough for a week or a couple days. With the muscle relaxer, a couple days, gabapentin, those you're going to need more, but give me a trial of it. Don't give me a whole month supply. I don't want 90 or 120 pills at home. I take a week's worth and it doesn't work or I can't take it. It just causes issues, right? That's the whole issue with the opioid epidemic is there's tons of pills around. Uh, these are powerful medications. They should be treated that way. So you don't want any of these meds to be around for a long period of time, just sitting in the house. The other thing I would just mention is a lot of these medications, when you look at the studies, and it's going to be rare if you get more than 20 to 30% improvement with these medications. So again, setting realistic expectations.
Yeah, I think
Uh,
there should be goals for the medication. So my two main goals are typically good sleep and good function. So if you're having trouble sleeping because of pain, let's get you one of these medications that will help with pain and make you sleep at the same time. And then um, obviously, you don't want to use that same medication during the day if it's making you sleepy. So let's find one that we can use during the day to get you to do what you need to do, and what you need to be able to do. So those are usually my two main goals for patients. And so usually when I'm prescribing like two medications, I mean, they're saying, give this a try. If that doesn't work, try this. Or one's, okay, this is at night and this is for during the day. And I want you to use these kind of differently. And that's the
yeah.
main goals probably.
Yeah. And I find myself using a lot of gabapentin or nortriptyline in the evening.
Yeah.
So if they have a lot of like leg pain, but difficulty sleeping, uh, those two medications, can help with nerve pain, but also can make you a little tired. So,
Yeah. I was using amitriptyline a good amount, um, and which is very similar to nortriptyline, obviously. And I found it made patients sleep so well that I had other patients from the waiting room coming to me to ask me to prescribe it to them because other patients were going around saying how well they were sleeping with this medication that I was prescribing them. So
how about that?
that was a pretty interesting response, and I saw that on more than one occasion. It wasn't just like one person. It was like a flock of people were like, give me this medication. So that was pretty interesting. I think I've gone away from amitriptyline a bit just because some of the Medicare plans have made it really difficult to prescribe to the geriatric population, and rightfully so. I think it's on the list of meds that kind of increases fall risk and stuff, but and then also I think there's some concern with some of these medications kind of increasing risk of dementia in older patients. So um, I try to keep the doses as low as possible when I use those medications. I use a very low dose, and try to keep the dose as low as possible. And, like you said, nighttime dose. For depression, some of these things are dosed like multiple times a day. I just use a nighttime dose for those.
Yeah, and like so amitriptyline or nortriptyline, if you're talking about depression, I mean you're on high dose.
Yeah,
You're on 100 or 200 milligrams. I'm using somewhere between 25 and 75 milligrams,
I'm using
usually at
10.
nighttime.
I'm using 10 milligrams. Yeah.
Uh,
And
yeah,
it's
yeah,
amazing that makes some people go to sleep like very much, but other people are walking around on 100, 150 milligrams twice per day. So you see all kinds of effects. So I always start as low as possible and just increase slowly, which, is something we always say.
yeah. When we talk about the next class of medications, opioids, for something like this. This is going to be its own upcoming podcast, but it's obviously controversial. It's the hot topic because of the opioid epidemic, and rightfully so. But when the one thing that the opioid epidemic did do was kind of shine light on the real lack of evidence to actually support its use, right? There's been a huge push towards what we call evidence-based medicine anymore. So looking at the studies, what's been proven to work, not just, what's been done forever or what works for this doc who has a ton of experience. And evidence-based medicine, there's no great research or evidence to support chronic opioid therapy for back pain, chronic pain conditions for more than 12 weeks. I mean, these work really well in the post-operative setting. They work pretty well for acute pain. I would argue they don't work that well for like acute nerve pain. So like if you have acute leg pain or sciatic type pain, they don't work that well. But yeah, I mean, so with the caveat around that, there's not great evidence for it. Oftentimes these medications, the risks outweigh the benefits in the subset of patients who we do feel are appropriate, who've kind of passed all the risk assessments, who have shown they can use this responsibly, and who have demonstrated both functional and pain relieving benefits with it. It is a class of medications that should be considered. What are your kind of thoughts? What's your philosophy?
Yeah, I think generally I start with other medications. If I trial a few in each category and don't get much result, I'll move into opioids. Generally start with the weakest ones and then just progress. And like you said before, just small supply, a week or two, try this out, see if it works. If it doesn't work, we'll change it. If it doesn't work, we'll increase the dose. We'll try to find something that works for you. So start low and go slow. Use the weakest ones, and just look out for any side effects and warn patients about the possible side effects. Generally constipation's a big one, and then fall risk in older patients, and drowsiness, sleepiness, that kind of thing, especially when we're starting at lower doses. When getting higher doses, I think everyone has heard about dependence issues and things like that. So
yeah, and we'll go into much more detail with this in subsequent podcasts. I guess the two things that I would just mention briefly would be, uh, whenever you start an opioid, it should be deemed a trial. My experience and the evidence has showed if patients don't respond to it at a lower dose, the likelihood that at higher doses it's going to have much more benefit is not that great. So, if we're starting someone out on opioids, again, I'll do what you described: shorter acting medications, either hydrocodone or oxycodone, usually. Sometimes like a morphine immediate release, depending on patient's pharmacy benefit coverage. If that one medicine doesn't work, I'll rotate to a different class or increase slightly on the dose. But if we're not getting any improvements, again, realistic improvements, 30 to 30% really in pain relief, but you should be able to do more while you're taking them. If we don't see that, even with an opioid rotation, I'll say, this isn't going to work for you. We have to figure out something else. Yeah. And this, the people who have had previous back surgery, we can't ignore that subset of patients have a 7 times higher likelihood of developing an opioid disuse disorder. So whether it's dependence or misuse or abuse of the medicine. So that's something that, we can't ignore. I don't think we know exactly why that is. I think there's a lot of factors that play into it, but these are things we have to be cognizant of. And I know we are when we're treating our patients. Again, sometimes the risk outweighs the benefit.
Yeah, that's it. It's a great
Yeah,
point. I don't ever want to contribute to a patient having a problem with opioids. So take it
yeah,
very seriously. I don't, we don't. I never just start one just to start one. There's always a process. Always try other medications and other treatments, and then, like you said, like we said, start low and go slow. And if it's not working, we don't just keep bumping it up. We try something different.
yeah. And although there's not great evidence yet to support its use, medical marijuana is an evolving, or I guess in some states, recreational marijuana as well,
Yeah.
is an evolving potential treatment option for chronic pain conditions as it relates to the spine. Um, I would argue, although the research isn't there, I think it's safe to say it's could be potentially much safer than opioids.
Yeah.
Right, the downside to opioids is much greater than the potential downside to cannabis. I mean, there's some nuances with that argument, but overall, you can't die from an overdose of marijuana. Obviously, now if you get behind a car and that's a different, behind the wheel, that's a different story. But
Right.
you can't take so much marijuana that you're going to die from it
Right.
compared to an opiate.
Right.
So,
Exactly. Um,
so
Probably just leave it at that because that discussion could get really hairy really quick. So,
yeah, we'll talk about that
yeah,
more in the future. But I mean, in all honesty, though, some of my patients are, if you're listening to this or watching on our YouTube page, if you have a lot of pain after surgery, chronic pain, and you're managed with some of the medications we mentioned, and it's not working, well, maybe that is something to consider if you're in a state that either allows it recreationally or medically. I would not recommend obtaining it illegally.
nice work.
Okay. Well, side note, right? With all the laced fentanyl and different things,
Yeah, of
you
course.
do not want to be
Of
buying
course.
cannabis off the street. And then when you hear everything with the whole vaping of black market cannabis,
Yeah.
it's scary right now.
Yeah, of course.
Um, okay, so now let's move into kind of what we do a lot of the times, and that's the interventions. And I think we've touched on these a lot in other podcasts, so we don't have to go in too great a detail. But
Yeah, I mean,
you
we're
know,
targeting specific pain generators. So, if we think it's a facet joint, we might do one of the things that we talked about in the facet joint podcast, a facet joint injection, a medial branch block, a radio frequency treatment. If we think it's a disc herniation, impinging a nerve or irritating a nerve, we may do an epidural injection like we discussed in the disc herniation podcast. If we think it's a sacroiliac joint, I don't think we did that podcast yet, but we'll do that at some point. We can target the sacroiliac joint with a targeted injection into the joint, or even a radio frequency procedure similar to what we talked about with the facet joints, but targeting the nerves that innervate the sacroiliac joint. So, we can the details for those procedures and ideas around them will be in the separate podcast, but I think, you know,
mhm.
we'll be trying to target specific pain generators just like any other back pain patient. And then of course there's I think we could go a bit more into, I think you do a little bit of spinal cord stimulation. I don't know if you were thinking about going into that right now.
Yeah, I mean, I think we need to at least kind of touch on it.
Yeah.
So just to add to what you said, I would agree. Facet targeted therapies, primarily medial branch blocks with possible radiofrequency ablation in people who have had previous fusions, work pretty darn well for back pain after fusions. Uh, and then epidurals, that's a tricky one, especially after surgery. Unless you have a new disc herniation, I, I tell patients, I mean, if an epidural wasn't done before surgery and you're still in pain, yeah, it's worthwhile. But sometimes after surgery, whether it's scar tissue or, stenosis from adjacent segment, I'm not overly impressed with what we get out of epidurals. Now, again, everybody's different. I think when you weigh risk benefit of potential treatment options, it's something the conversation should be had. But especially if you have scar tissue wrapping around a nerve, I tell my patients up front that I'm not entirely sure how much an epidural is going to be able to help you.
Yeah.
Uh,
Yeah, I agree.
that,
I definitely, that being said, I've definitely seen people who, I was like, look, this probably isn't going to help. And then you do it and they feel so much better. And you're like, okay, I don't know why, but it worked. And maybe there was a little
yeah,
bit of disc herniation on top of the scar tissue, like,
yeah,
yeah.
yeah. I guess when I see patients who have back and leg pain after a fusion or decompressive type surgery, and the surgeon either offers them a very extensive spine surgery or no other option. I do talk to a lot of my patients about spinal cord stimulation, and we can talk more about this we could go in a whole hour on this,
Yeah, we
but
should at some point,
when
definitely.
yeah, but when you look at the data, previous patients who had previous spine surgery continue to have pain, and the options being that of either physical therapy, injections, repeat surgery, or spinal cord stimulation. Spinal cord stimulation has the best data to support its use in those patients when you have a lot of leg pain after surgery. So it's definitely a conversation I have with a lot of my patients. It's not for everybody. There's a trial, which is the best thing about this therapy. So it's 100% reversible for the first week. You go home with a Band-Aid after it's all done. There's no incisions. And then we figure out if it's an option for you. You'll hear, if you talk to 100 people, you'll have 50 people that love their spinal cord stimulator if they get it put in, and then 50 people who don't. And my opinion is the reason that is the trial wasn't used responsibly. And we'll go into more detail with that in subsequent podcasts. But I really do think that if you're living with chronic back and leg pain after a fusion or a lumbar spine surgery, spinal cord stimulation should be something that is looked at.
Do you have a hard time convincing patients to do something like that? I find that the the low number of patients that I've had who have had a surgery on their lumbar spine and then continued with pain, most of them just don't want another procedure on their spine. They just say, no,
Mm-hmm.
I'm not letting anyone touch it again. It still hurts. They messed it up, or it never got better, or something, or I had an injection and the injection made me worse. Do you have a hard time? Do you find a lot of those patients you have a hard time convincing them?
Uh, I don't think so. I think there's a subset of patients who, I mean, they don't want anybody to touch them at all,
Yeah.
like you mentioned. I mean, most of those won't even want to do an injection or anything. But I would say majority of patients, I frame it as the trial is complete 100% reversible. There's no incisions. It's like an epidural, and then we just put a little wire in. It's almost, I compare it to a pacemaker for the spine. And for the week, my patients, when after the trial, the the ones who the trial really works for, they come in wanting the implant. You know,
Mm-hmm.
does that answer your
Yeah,
question?
yeah,
So,
yeah.
I mean, there's some that are against anything, but I would say the majority of them are at least open to the trial um, after I kind of go over everything in detail and kind of show them what the studies show
Right,
with regards to it.
right.
But I reassure them that we're going to use it responsibly.
Yeah,
I think that's something that's not done enough. Just like lumbar spine surgery is overutilized, I do think spinal cord stimulation is also overutilized.
yeah,
And then it gets a bad rap, right?
yeah,
I mean,
of course.
just like with spine surgery, in the right patient, it could be a game changer. But when it's overutilized, then you start to hear a lot of negative outcomes, and then it kind of snowballs from there.
One other thing that just anecdotally, I had a patient failed failed spine surgery and had a lot of scar tissue around the S1 nerve kind of behind the L5S1 disc, and we actually treated with pulsed radiofrequency ablation, which, similar concept, as maybe kind of resetting the nerve, and had really good results. Actually, the patient had like 3 to 4 months of great relief of the pain, and came back, repeated it, had great relief again. And after I had left fellowship, someone messaged me that he came back again and had great relief again. I haven't heard since, but came back a few
Yeah.
times in a year and had great relief. And it was something that it was kind of like a shot in the dark that we did it, because we were running out of options for him, but we were pretty confident which nerve was causing the problem, and we figured
So
we'd just give
you
it a shot, and it worked.
so you did a pulsed RF of the DRG
We did,
of L5 or what?
no, of S. So we went through the S1 foramen, like a typical kind of
Yeah.
transforaminal approach. So, I couldn't say that the DRG was there, but the first time we did it, we had done multiple specific diagnostic blocks of nerves and joints and the SI joint and facet joints, to determine what kind of helped his pain the most. And what really helped the most was a selective nerve root block of the S1 nerve with like a little bit of 4% lidocaine. And so we said, okay, we did an epidural there. It didn't provide any long-term relief, kind of like what you said. And then we thought, okay, let's try this. There's been some reports about pulsed RF.
Mhm.
I think some people kind of swear by it. I think there's some practitioners out there who do a lot of it for different painful conditions, for peripheral nerve issues. But we decided to do it, and it happened to kind of work really well for this guy. So, but
Yeah,
it's
that's
maybe the same concept as the spinal cord stimulator. You're kind of modulating the pain signal in the nerve,
mhm.
and maybe we were able to modulate that a little bit for him, and and then after time it seemed to come back, and that was probably from all the scar tissue, but he did have relief with that procedure. So something to think about for the future,
Yeah.
if we're
It-
struggling with patients.
yeah, that's interesting. I mean, I guess the tough part would be just getting insurance coverage. I think
Um,
there's
yeah,
some barriers with that for pulsed RF, but
I think
I mean
what we
that I
did honestly was we um, did an epidural at the same time. So
and just
we
build for the
so we
epidural.
had done an epidural without any relief, and then we just did an epidural with the pulsed RF needle, and then
Gotcha.
turned it on, and then injected the medication after we had done the pulsed RF.
I gotcha. So you
Yeah.
just build for the epidural.
Yeah,
Okay.
basically, because it was just
Interesting.
like the
Interesting.
needle placement and injection of medication. So, yeah.
Yeah. Interesting.
Yeah.
Um, eh, okay. So I guess that just to be complete, I guess there is intrathecal morphine pumps or intrathecal opioid drug delivery systems. Um, all I'm going to say on that is they were popular years ago. Uh, we ended up finding out that there was a whole bunch of issues with them. You had a lot of patients who ended up on a very high dose of concentrated either morphine dilaudid or fentanyl in their pump that would be delivered into their spinal cord and all the fluid around their nerves. And they were also on high dose of opioids by mouth. It's fallen out of favor. Even the companies that make them don't kind of advertise for that type of treatment anymore. They're starting to push for this low dose or micro dosing, but they actually want all patients off of opioids before you go down that route with these pumps. So, I think just for completeness sake, we kind of round it out with that,
Yeah.
but it's very rare that those are done as much anymore.
Yeah. I don't see. I don't have much experience with pumps, and I don't even see many patients. I have a few patients here and there who maybe have a pump that like isn't functioning anymore, or they used to have a pump and they maybe had it taken out. But
Yeah.
yeah, I don't manage any, and I don't, I don't have any patients who are using them. So as far as I
Yeah.
know of, at least, yeah.
Oh, you would know.
Yeah, I think so.
Um, okay. Well, anything else you think we missed or
No,
you
I think
want
that
to
was
cover
pretty
tonight?
good. If you have any questions, of course, you can email us or comment on the video on YouTube, or comment on one of the podcast services. But yeah,
Yeah, our Facebook page as well.
yeah,
That's where we got the idea from this podcast. So we're always receptive to hearing, if there's a certain condition that affects you and you want to kind of hear our take on it, or any specific, whether it's the treatment or the diagnostic part of it, anything we can do, we're more than willing to help. So that being said, Dr. Bonner, it was a great talk,
all right.
and I look forward to doing it next week.
Yeah, have a great night.